There we go. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, April 21st, and it is time for another IC support group meeting. It is a absolutely gorgeous day here in Northern California. It's our first day where it's actually warm in the morning, and we could go walking out in shorts. I don't know about you, but it's been a long winter and I am ready to enjoy some sunshine. So I am the founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader here in the United States. I'll be 31 years in September. Can you believe it? I cannot believe it. My purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you. I don't want anybody telling you that you're damaged goods. I don't want anybody telling you that it's all in your head. And speaking of that, when I do these meetings, I always start with it's just basic educational information. And I attended a fascinating course on UTI and pelvic pain Friday, and it blew me away. So think about all of those patients who have shared that their IC symptoms began after an infection. You know who you are. I mean, remember, we have tremendous diversity in the IC patient population. For some people, it begins after they fall and break their tailbone. For others, it begins while they're going through chemotherapy, et cetera, et cetera. But there's always been a pretty substantial group of patients who have shared, I think mine began after I got an infection. Well, prepare to have your mind blown. So this course was taught by Dr. David Klump, who's a very big NIH IC researcher. I think he's on the board of the ICA, as a matter of fact, the Interstitial Cystitis Association. And he was sharing some of the new UTI research that they've been doing. So bacteria. So think about E. coli for a moment. E. coli is going to be one of the most common and often quite virulent UTIs that a person can get. And there are many different kind of families many different types within the E. coli family. And so what they're now doing with next generation DNA testing is they're able to look at distinct and different types of bacteria to see what role they play in pain. And here's what they found, that for some people, when you get a pathogenic bacterial infection in your bladder, obviously the bacteria is infecting the cells of the bladder wall. They're foreign invaders. The body doesn't like it. They start to break down tissue. They basically turn cells into bacterial factories. Then the bacteria within the cell consume all the resources in the cell. Then the cell ruptures open and releases all these bacteria to then infect other cells. And sometimes what happens is you get kind of bacterial tunnels where one layer is infected, it sloughs off, then the bacteria go to the next layer, it sloughs off, then it goes to the next layer, it sloughs off. So it makes sense that when you have a severe pathogenic infection, you're going to have severe pain. And it also makes sense that as that infection is treated and those bad bacteria are killed, that you would start to feel better. And so, in other words, the pain rises, and as the infection rises, and then the pain drops as the infection resolves. So that makes total sense. But they have now found that there are some bacteria that turn on chronic pain through a very specific pathway. And so here you get a pathogenic bacteria, your pain goes whoop right up. They kill the bacteria, but the pain doesn't go down. The pain, and actually it's not quite that, it's like that. that if you're unlucky enough to get, I think they talked about staph, they talked about a very specific E. coli, couple, Enterococcus facialis, which is we certainly know is playing a bigger role in UTI. It's a very confusing bacteria. So if you're unlucky to get one of these specific types of bacterial infections, it can turn on chronic pain, and that chronic pain can persist even after that infection is long gone. Daunting, discouraging, upsetting, correct? But they've also created a sister bacteria that doesn't trigger any pain at all and basically turns off the pain. And so it's another E. coli in that same family. And so this is very, very new research. It's obviously preliminary research, but it's creating the foundation and the case for treating UTI not with an antibiotic, because we all know that antibiotic resistance is soaring. It's so incredibly bad. And ultimately, in the end, inside of our body, we have a biome. And the way the pathogenic bacteria are controlled in the human body is by good bacteria killing the bad bacteria. That's the way it's supposed to work. The good bacteria kills the bad bacteria. So they have now developed a strain that will kill these bacterial infections that can cause chronic pain. So, as I've said multiple times in our live streams over the last couple of years, we're getting closer and closer to the point where simple bladder infections or complex bladder infections will not be treated with an antibiotic. They'll actually be treated with a good bacteria that's designed to kill the bad bacteria. Fascinating. Another thing that they're doing for these super, super, super drug-resistant infections is they're using bacteriophages. And a bacteriophage is actually a virus that can deliver a payload that can kill the bacteria. So that's certainly in the works right now. And I swear, who was I talking to? I think I shared a couple of weeks ago a patient who called me who very, very intense urinary symptoms, diagnosed with UTI, not particularly responding to therapy, or the bacterial infections were very, 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 very persistent. And so she decided to do some next generation DNA urine testing, and that came back with 3 bacteria that I had never heard of, really rare bacteria. One of the bacteria, I think, was associated with heart infections. Another one was associated with sepsis. Anyway, and so her question when she called me was, what do I do about these weird bacteria? And I'm like, I've never heard of these bacteria. Let's look them up. So we looked them up. They were shocking to me. And really, they were a sign that her immune system was greatly compromised. It's like, okay, we don't just want to treat the infection. We want to figure out why you're so vulnerable to infection in the first place. Like, why is your body a safe haven for bacteria right now? And it strongly suggests that there's an immune issue, that her immune system was dysfunctional. In fact, she had shared that her IgG levels, immunoglobulin G levels, were very, very low. The doctor wanted her to do IgG therapy to boost her immune system, and she'd refused. So why was she struggling with these rare bacterial infections? It's because her immune system was greatly, greatly compromised. So anyway, I'm very, 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 very encouraged with what I'm seeing. This is exactly what we want. We want to see the need. Number one, it absolutely validates those patients. Ashley, I don't have the names written down. They were not one They were variants of E. coli's and the variants of staph. And so I can tell you it was E. coli. I just can't tell you what the word that goes after it. I just saw it on Friday. I mean, I just participated in the class on Friday. One of the questions I asked the researchers, I said, okay, since we have this pretty clear data now that there are certain strains that can cause chronic pain, can we use next generation DNA urine testing to validate this patient's experience? Because most of these patients who have chronic pain have been told that it's all in their head. And so, isn't this potentially a fabulous role that next generation testing can say? Because if it reveals that this patient is indeed infected with one of these more painful strains, it would validate that. It's like, no, it's not all in her head. Look at this. She's got one of these rare bacteria that are known for causing long term persistent pain. So, Ashley, I will be doing an article on it, I'm sure, in our next magazine, which I've got to start writing next week. And so I will have that information for you for sure. But and I actually want to try to interview one of the researchers or two of the researchers so I can get a little bit more information on it. But my point here is telling you that really good things are happening. I want to validate some of your pain experiences for those of you who believe that your symptoms began after infection. That is indeed what they are finding for some patients. And again, even after they kill the bacteria, for some of these bacterial strains, the pain can remain. So we've got now another strain of E. coli that can turn that off. So it's very, very complex. It's very, very advanced, but it's also quite preliminary, but it's looking good. So hello, Cardsty. Hello, Angel. Nice to see you on YouTube right now. We're simulcasting live. We're simulcasting. If I'm looking over here, I'm looking at YouTube. If I'm looking here, I am looking at Facebook. Hello, Ann. Ann says, can I use a rectal wand for coccydynia? My PT threw it at me and I didn't feel comfortable doing it. What do you mean your PT threw it at you? If your coccydynia is manifested as tight pelvic floor muscles, yeah, definitely. But hopefully they're going to teach you how to do it correctly. They don't just give you the wand and say, go do it. They've got to tell you how to move the wand, where you need to locate the wand, et cetera, et cetera. Cardsy says, your hair looks great. What's my secret? My secret is Earth Sciences hair balm. that's what keeps it calm. I'd be happy to give you a link later if you want to give it a try. I swear by that stuff. And she says, avoid animal products to not get E. coli and wash all my vegetables and leafy grains that animals may poop on. Yeah, I mean, absolutely. I mean, I think we all have to understand and acknowledge that these very, very severe drug-resistant infections are coming from large animal farms. Doesn't matter if it's chicken, pork, or beef. I can still remember there was this really interesting case of college students in Washington, Oregon, and Idaho who all got this really rare, very drug-resistant bladder infection. And they were able to trace this very, very specific infection back to a specific feedlot where they were using a lot of antibiotics on the beef. And it happened to be that this specific feedlot supplied the university commons where they served the food. We also have very clear data that supports that some very, very drug-resistant E. coli infections can come from wide-scale pork producers that started in China, spread to Europe, and then finally arrived here in the United States 7, 8, 9 years ago. And these are superbugs that do not respond to normal, typical therapy. And of course, many of you should remember the great Costco chicken debacle, where people were eating chicken that was purchased at Costco, and some got very, very ill. And I do believe that a few people died, but don't quote me on that. But I think that's possible. I know it was this massive, massive issue here in California. And they traced this specific strain back to very, very specific chicken producers. And they even named the strain after Foster Farms or something like that to help identify that this specific antibiotic resistant E. coli infection or very virulent E. coli infection came from a very large chicken producer here on the West Coast. And so I think it's very, very important that for those of us who are worried about UTI, that we clean up where we get our food. I always look for small producers, local farms, rather than big farms. And I will tell you quite honestly, I haven't eaten a hamburger from McDonald's in 20 years because you don't know where the meat comes from. And I'm just not interested in doing that to my body. I really want to do everything that I can to be as healthy as I possibly can. So it's all the factory farms. I mean, they're just devastating. And ultimately, it's big business. And I don't know about you, but I'm getting real sick of the billionaires right now profiting off of making animals sick and making us sick. We didn't have these mega feedlots 50, 70, 100 years ago, and people were not struggling like they are now with finding good quality food. So, and food that isn't painful. And at the same respect, hello, Diane. We also have to make sure that when we're for example, my this is my breakfast. I haven't eaten yet today, believe it or not. And this is a smoothie with organic banana and organic mango and strawberry, and then I threw in some organic blackberries in there. And as I was thinking about that, I was going, I was remembering my Dirty Dozen and Clean 15 list. So what are the foods that are the most notorious for having a lot of pesticides and other chemical residues in them? And strawberries are icky, potatoes are icky, French fries are icky, depending upon where you get the source. And this is about you can't just peel it and get rid of the pesticides. The pesticides are actually in the meat of that fruit and veggies. So if you're ever interested in looking at the foods which are the cleanest to eat versus the most risky to eat, you want to Google Clean 15 or Dirty Dozen, and that's from the Environmental Working Group. Love them, love them, and they're pulling data from our government's own testing that's validating that yes, there is some of these big giant farms are cutting corners and they're using things they shouldn't be using. It doesn't matter if they're here in America or they're abroad. They're still finding banned chemicals, known carcinogens in the foods some of the foods that we're eating. Why? I gotta tell you that I was cleaning out my dad. My dad did not have a healthy respect for the harm of chemicals, even though like all three of the children, we're all scientists and two of us are chemists. And it didn't matter what I said to him. He simply didn't believe it. He's like, I was in the Navy in World War II. I was exposed to formaldehyde. I'm 100 years old. I'm fine. I found literally a old bottle of diazonon in my garage. Like, what? Shocking to me. Absolutely shocking. Anne said, the physical therapist, you don't like your physical therapist. What about a chiropractor for coccydynia? No, honey, you got to work on the muscles. How about finding another physical therapist? Time to look for another physical therapist. So go to pelvicrehab.com to do that. Louise says, hey, Jill, been thinking about you. Thank you. I'm currently in a rehab recovering from a near-death experience. Woman, I got sepsis, had a small bowel resection, and I'd love to talk with you someday about dealing with IC, things that may help others, dealing with doctors. I'll be home after May 1st, doing much better, but learned a lot and educated many medical staff about IC. Louise, absolutely love to talk with you. I'd love to hear how you're doing and any new wisdoms you have to offer. Absolutely. Hello, Sue. Sue says, hope you're having a beautiful Sunday. Listen, I have been extremely productive today. I got out and did a really long walk at 9 o'clock. Then I came home and worked in my garden. Then I washed my car. It's warm outside. It's so nice. I was watching some crows. There was a hawk circling over some trees that a crow's nest was in. So the crows were dive bombing the hawk. It was, just a lovely day. You know, I just, I think it's just so important for us to get up, get out, and get moving. Get moving. Got to get walking. Remember that the more you exercise, the more you produce your body's own natural endorphins. These are your body's own natural painkillers. So every day, if you can, get out and walk. Get out in the sunshine. When you're in the sun, we produce vitamin D. That's also very, very good. So get out and enjoy the day. Lizzie says, hey, Jill, don't want to jinx it. Finally got my estrogen cream a year later. First time ever. I don't have urgency, pressure, irritating pain. Yeah, baby. This is fantastic, Lizzie. So what does that mean? That means you are a genitourinary syndrome of menopause patient. And now that you're using estrogen, that estrogen is being absorbed into those cells and producing that nice thick coating that normally protects your bladder, protects your urethra, protects your vulva, and protects your vagina. So that's absolutely fantastic. You guys, hopefully you know that one of my causes in life is to reach those millions of women who have been told they have an incurable bladder disease when in fact they just have estrogen atrophy, dry skin affecting their urethra, affecting their bladder, and that topical estrogen can reverse that. So I'm so happy for you, Lizzie. Fantastic news. Sue says, for 20 years, I used that chemical on dogs and flea dips with a shot full of 7. We literally inhaled this stuff, had it on our skin from our elbows down, absorbing it, not realizing not realizing how toxic it was. I'm amazed we don't have cancer. There's a lot of very mixed information about flea products. I'm really, really convinced that I've lost 2 cats to flea products. My first one was Schutza. His name was Schutza. It was a white cat with orange ears. And no. It was Xander. It was Xander and Oscar. I inherit a lot of cats from neighbors. So Xander was this gorgeous tabby, and Xander and Oscar used to sleep together. They were just a sweet little older cats that had lived together for years, and they had fleas. And I took them to the vet, and the vet said, "Let's do some flea drop." This was way back when, and they said they only had the dog drops. He didn't have the cat drops. They said, "Oh, it's fine. Just use this." And Xander immediately went into kidney failure. And I gave him IVs. I gave him fluid for a year before he finally passed away. And hello, pharmacologist. I looked at them, I questioned them, and I said, "Are you sure this is safe?" And they said, "Yes, this is safe." And it was not safe. And I think my Sammy too, my last cat that I had for 20 years, I think the flea drops really messed with her too. So it's very hard. I don't have any pets right now. Hello, Jolene. Jolene is watching for the first time. Hello, hon. How are you today? How is your IC? Hey, you guys, how are you feeling today? How is your IC today? Anybody flaring? Anybody struggling right now? Sue says, "Oh my, I'm shocked. A veterinarian told you could use a dog product on a cat. I have had clients kill their cats by doing that, not knowing that they would go into a seizure and die." I know. Lizzie said, "That's so interesting. I never did anything to my cats. No vaccinations, no drugs. This cat's like 20. My dog, when she did live a long life, got cancer and we did it all." The other big issue is The fire retardant that's put in our furniture. You know, from like 1960 to literally, it's still happening around the world. They started putting fire retardants, and the retardant industry got the government to pass a law saying children's clothes, bedding, everything should be retreated with a fire retardant before it's sold. And now we know that those fire retardants absolutely cause cancer. And the problem with putting a fire retardant in furniture and in the foam, it's in the foam in the furniture, is the foam breaks down into a powdery dust. That dust then ends up on your floor, where if you have children and babies, they walk through the dust, they swallow the dust, cats, dogs. And my vet actually said that's exactly why we have millions of cats and dogs now with cancer, is because of those flame retardants. Yeah, and it's in kids' clothes, and it's undeniable. California banned it. I love the state that I live in because we're proactive. We try to help people and we try to protect people. So we banned the use of these fire retardants a good 8-9 years ago. But you never know. If you never know. In fact, there's a service online where if I mean, whenever I go and buy furniture, um, uh, I just flat out ask. I don't want it treated with anything. I don't want fire retardants, nothing in this furniture. I don't want stain preventers, nothing. And if you suspect that there is something, you can actually send in a piece of that foam and get it tested. And that's a free service that a couple of universities offer. I actually returned a sofa and chair from Lazy Boy. I said no treatment. Oh my God, it was awful. It was so bad. Hello, Boria. Yamo says, my doctor told me I have overactive bladder. I feel pain during urination, sitting, also sleeping, pain in the uterus, vagina, and rectal area too. So Yamo, so the fact that you have pain excludes you from a diagnosis of overactive bladder. Overactive bladder is really frequency urgency in the absence of pain. So the fact that you have pain puts you into the chronic pelvic pain group. And your symptoms are very, very important here because what you just said is that you have pain during urination. So I would ask you, where is that pain when you pee? Is it on the outside, on your skin? Like, does your urine feel hot? Or is it inside of your body? That's concept number one. Concept number two, when you have pain, do you have pain when you sit down that gets better when you stand up? Pain when you sit down that gets better when you stand up. Pain that's positional in nature. You're fine when you're walking, but as soon as you stop and sit, it comes back. Or if you bend over, that's muscle and nerve. That's nothing to do with the bladder. That is pudendal neuralgia. Or if you have sciatica, that's a perfect example of a tight muscle squeezing a nerve. In that case, the sciatic nerve, which causes that shooting pain that goes right down a leg. So pain in your uterus, vagina, and rectal area, that could be pelvic floor pain. And so, Yamo, what I would want to do is, what did the physical therapist find when you went in? You say you're doing physical therapy now. So what did the physical therapist find at your first appointment when you had that pelvic floor assessment? Were your muscles tight? Bet they were. Eddie says, Jill had blood work done and my testosterone levels were low. Urologist then gave me a testosterone shot. Could this help my IC? You know, that's something that I need to study more. Honestly, I don't know how to answer that question. We have always looked at the role of estrogen and how the cells absorb estrogen and use estrogen to produce mucus. I'm a little bit unclear the role that testosterone plays in the female body. And so I wish I had a good answer for you. I was reading about it literally in the last month, but I just don't remember what I read. So I can't give you an answer for that right now. Hello, Paula. Hey, you guys, tell me where you're from. Where are you from? What state are you in? Sue says, my mother, who was a bright redhead, got a brand new mattress. And after the first night, her body broke out into a red rash. She didn't connect it to her mattress for a while. She finally figured it out. had a really hard time returning the mattress, but they did take it back. And then she had a hard time finding one that did not have it. So, Sue, what do you think that she reacted to? Hello, Kayleen. Girl said Kayleen had to go have an MRI on a Sunday. She had to take a drive and looks like she's home and the MRI went really good. Yeah, baby. Yeah, you did it. Good job. Deborah is from North Carolina. Jenny is from California. Jenny, I'm up here in Sonoma County, California. Lizzie is from Canada. Paula is from Traverse City, Michigan. Paula, I almost moved the IC network up to very near Traverse City several years ago when I fell in love with a police officer in Michigan. I dodged a bullet there. Let me tell you, I was months away from moving everything. Ursula from Virginia. Heather is from Florida. Heather, I was talking to a very, very old friend of mine that we were professional tennis players together, and he now lives in Florida with his wife, and we had a really great talk yesterday. And I was saying, boy, if there's one state that would tempt me, it would be Florida, if the political climate were a little bit better. Hello, Val from Canada. John is from Wisconsin. Jolene is from Florida. Excellent. Gina says, do you have any information or proof that statins for high cholesterol cause pelvic muscle achings or bladder problems? Well, let's look it up. I'd be happy to look that up for you right now. Now both of my computers are filled with all these open programs because I'm working on our master class, and I uploaded the oral medication master class on Friday, and the bladder installation one is done, and hopefully I will be uploading that either today or tomorrow. And then the master class, this is a series of free videos on all things related to IC that start at the beginning from diagnosis, goes through self-help, goes through various treatments. We'll be covering a lot of diet information, a lot of flare management information too. It's all filmed. We're just in production now. Okay, so let's get back to our questions here. So you can watch that on if you just go to the IC Network website, icnetwork.org, up in the main menu, there's a new link that says IC 101 Masterclass. Just click on that. You'll see them all. All right, so hold on one sec. Let me get back to this question, and that is statin medication. I did learn something new because I've been dealing with a very, very tight neck. I've got a new physical therapist. A lot of it's from my scoliosis, but it's also from working at a computer for long periods of time. And I started having some muscle tremors like about 6 weeks ago. Yeah, it's from my flexural. That's what happens when you take medications for a long period of time. I've been taking it every day for about 3 months. Now we're back off of it because I do not like having muscle tremors. Okay, so let's see. So yes, statin side effects statins are well known for causing muscle pain, headache, constipation, bloating, nausea, muscle pain, dizziness, diarrhea, abdominal pain, unusual tiredness or weakness, dark urine, fatigue, heartburn, arthralgia, problems sleeping, rash, and a stuffy or a runny nose. So, Gina, if you just Google statin medication side effects, you'll find it right there. No doubt about it. Beagle Mom is from Lake City, Michigan. I love Michigan when I visited. Beautiful state. Diane said, I'm still struggling with urinary frequency and pain. I've heard you said it takes 3 months following the IC diet religiously to heal my bladder, but I wonder how long before your bladder feels better. Well, Diane, it depends upon your phenotype or your subtype. So, for example, if you have Hunner's lesions, your bladder is not going to feel better until you get the lesions treated. And following diet can help prevent a lot of pain, but it's not going to stop the pain. Well, what would stop the pain, hopefully, in most patients, is treating the lesion correctly. If you are a genitourinary syndrome of menopause patient, an estrogen atrophy patient, then I think a good 3 to 6 months on the diet would really help tremendously in giving your bladder a chance to heal. So I think this is important. This is an important concept for people to think about. The bladder is the slowest healing organ in the body. Why? Because it has the largest single cells in the body. The bladder lining is covered with what we call umbrella cells. These are ginormous cells that have very tight junctions. And so they're really tightly fitted together so no urine can get through them to get where it's not supposed to be in the body of the cell or in the body of the bladder lining. So when one of these cells is broken and damaged, there's a little tiny stem cell that is the next generation cell. But it takes that stem cell 2 weeks to grow and change shape and then fill in where that umbrella cell was lost. I learned this from a class taught by Dr. Anthony Schaefer years ago. And here's the thing he said in the class. It's just so really important for everybody to understand. That stem cell, while it's growing in to try to heal that wound in your bladder, is exquisitely vulnerable to acid. The acid will kill it. And he said, coffee will kill it. And of course, for all of this was at a National Institutes of Health IC event years ago. So I was sitting next to my United Kingdom counterparts, my European counterparts, etc. And he goes that, and we all looked at each other and we nodded and went, yeah. It's the patients who have 1 cup of coffee a day or 1 tea a day, or who continue to eat strong acids a day after they have a bladder injury that will never get better. Because it's physiologically impossible for the bladder to repair itself if you pour acid on the wound every day. And what would happen if you poured acid on a wound on your hand every day? Is it going to heal? No, it's going to get worse. It's going to start red, and then it's going to get darker and redder, and eventually you're going to have a wound there. And if you're foolish enough to continue to pour acid on the wound, it's going to get bigger and bigger and bigger. So your job as the patient is to create an environment that will help these tissues heal. And that means you got to lose the bad food for a while. You got to lose the bad drinks for a while. And you cannot cheat. 1 coffee or 1 soda sets you back 2 weeks. You destroy the entire generation of stem cells. So if you have 1 cup of coffee a day, you'll never get better. Because you're just killing the next generation every single day. That's why being on that diet, good 3 to 6 months, is so incredibly important. All right. So Diane, good job that you're following the diet. Keep to it. Keep to it. Yamo, you know what, Diane, I also want to say here to you, have you had anybody look in your bladder? Listen, normally the way a urology clinic operates is when you come in with quote unquote frequency urgency pain and they rule out all the hard stuff, they will send you on your way with an antidepressant, antihistamine potentially, and the diet, and they'll say, come back in 6 months and let's see how you do. And most patients, when you just change that diet, we do a lot better. Patients start to get better. But for those patients who, even when they're on the diet, they get worse and worse and worse and worse, and 6 months later, you're in worse shape, that's when that doctor is going to want to look in your bladder. And that's when you want them to look in your bladder. I mean, my rule for me is if I'm in pain, I want somebody to look at it. I'm not interested in guessing. I want facts. You look in my bladder and tell me what the heck is wrong with my bladder. And so, Angel, Yamo, I think that when you do your next check-in with your doctor, you have to ask yourself, do I feel better or do I feel worse? Am I responding or am I not responding? If you're not responding to treatment, if you're getting worse rather than better, the AUA guidelines are very clear. The AUA guidelines say stop what you're doing, take a step back, and revisit the diagnosis. What have we missed? Could we have missed tight pelvic floor muscles? Could we have missed pelvic congestion syndrome? Could we have missed endometriosis? Could we have missed a rare UTI? Could we have missed a urachal cyst? There are lots of things that can trigger the symptoms of IC. And especially if they look in your bladder and you have a normal, healthy bladder, that's when you really look beyond the bladder. It's like, okay, patients are always confused. They're like, but wait, I've got IC. How can I possibly have a normal bladder? And then they start doing all these bladder treatments. You got to celebrate that. If you've got a normal, healthy bladder, God, you've got a healthy, normal bladder. That's fantastic news. Now we have to look beyond the bladder, try to figure out why you're having symptoms. And in many cases, it's really based upon injury and trauma to the pelvis in some way, specifically to the pelvic floor muscles and or to nerves. Angel says, have I heard about the surgery they're talking about? Angel, you got to give me more information on the surgery. There's a lot of different surgeries that are performed. Oh, the sacral nerve stimulation? Honey, sacral nerve stimulation was actually invented here in California 30 years ago. I actually ran the support group for the patients who were getting the early sacral nerve stim. We have a lot of information on the IC Network website about this. So again, if you were talking to me on the phone and we were doing coaching, we wouldn't be talking about treatments right away. We would be talking about phenotyping. I have to try to, you, me, and your doctor, we all have to try to understand your anatomy a little bit more. What could be driving these symptoms? For some people, it's a viral infection in their bladder. That's called a Hunner's lesion. And there are other causes for lesions besides viruses. For others, that second phenotype, bladder wall driven, that can be a chemical injury to the bladder or estrogen atrophy of the bladder. A third phenotype is pelvic floor driven. Those are patients who have tight dysfunctional pelvic floor muscles. Our fourth phenotype is pudendal neuralgia. These are patients who have muscles that are squeezing nerves. And our fifth subtype is that widespread pain central sensitization. These are patients who have IC, IBS, vulvodynia, TMJ, migraines, et cetera, et cetera. That's where we're looking at the central nervous system. For that group, we have to focus on treatments that will help restore balance in their central nervous system because they have a central nervous system injury, and that is, in fact, my group. So sacral neuromodulation is, I'm going to say controversial. It was introduced years and years ago. And the way that they used to introduce it to doctors was, hey, that patient who drives you crazy all the time, they always call you, they're flaring, they're always calling you, they're very, very annoying. You can get rid of them if you do this neuromodulation device, which involves basically a TENS unit and then a lead that goes down to either the pudendal nerve or into the sacrum to try to remodulate those nerves. So it was very offensive the way it was introduced, and it turned out to be a very nice moneymaker for doctors. They made a lot of money when they did neuromodulation. But now we have much clearer guidelines on when it is appropriate and when it is not appropriate. Generally, we want you to do the less invasive things before you do anything that's surgical and invasive. And in neuromodulation itself, again, I have a ton of information over on our website. There are 3 different types of neuromodulation. You can do it at the ankle, that's post-tibial nerve stimulation. I did that because I was a patient at UCSF, and I thank God that I was in the ankle group rather than the sacral neuromodulation group. The goal here is if you gently stimulate the nerve, you can break the nerve, you can calm that nerve down. I still have tattoos. I think I've shown them many times. Hold on a sec. Bear with my knee brace. I don't know if you can see that little dot right there. See that little dot right there? That's where they did it. I have little tiny tattoos in both of my ankles. And the advantage of doing the ankle stimulation is it's not associated with any great side effects. They're very, very, very few. The last time I looked, less than 5 reports of adverse events with the FDA. It doesn't involve surgery. It's literally an acupuncture needle. It's a vector to the nerve with a little TENS unit. You sit at the doctor's office. They put the needle in. They attach the TENS unit to it. You sit there for 20 minutes. And I will tell you that it helped me. It broke me out of a very severe year-long flare. I had my first 2 hours without pain at week 4. I had my first day without pain at week 10. And believe me, I'd been living with very severe pain that year. Now, I am a neuromuscular patient. I have a healthy bladder. What it did is it calmed my nerves down in my pelvis. You compare that with sacral neuromodulation inner stem. Number one, it requires at least 3 surgeries. So you have to have a surgery to implant the lead. You have to have a second in surgery to implant the generator. And then you have to potentially have multiple surgeries to replace the batteries as they wear out. And last but not least, if it doesn't work, you have to have explantation surgery. The challenge with sacral neuromodulation, if you look at the FDA database, is the adverse events are shocking. There are hundreds and hundreds and hundreds of reports of patients who have been harmed. Patients who have developed deep tissue MRSA infection. Patients who, there was one patient, one time when I was going through it, whose heart beat in time with the stimulator device. There was a very passionate doctor who was filed a strong concern about it. He basically a warning about it. Why were so many patients getting deep tissue multiple resistant staph infections? And part of the challenge he guessed was that the site of the surgery itself was down in the pelvis near the rectum where there's a lot more bacteria. So, and I think the biggest concern, well, there are 2 other concerns with sacral neuromodulation. Number one, will your doctor care for you if you lose your health insurance? Because this is not a one and done. If you have a device put in your body, it has to be monitored consistently. And we had a patient in Florida who had it done. Then she got fired from her job. She lost her health insurance. She ended up on Medicaid. Her doctor dropped her and her device was malfunctioning and it was shocking her. It was physically shocking her. And the doctor who implanted the damn device turned her away because she didn't have health insurance. And she called me sobbing, "What do I do?" And we immediately called the company and said, "Hey guys, we got a patient who's having an adverse event that's quite severe. You need to get her care." And they stepped in and they found one doctor in the state of Florida who would work with a Medicaid patient. One. So that's an important question to ask your doctor if you're considering sacral neuromodulation. If I lose my health insurance, who's going to care for me? Will you care for me? Will you promise? Will you put in writing that you will care for this device even if I lose my health insurance? Because that patient was desperate. She was in pain. It was hurting her. And the doctor refused to care for her. Now, last but not least, the last thing to know about any of these implants is you need to make sure it is covered by your insurance. So I have the story of a nurse back east. She lived in a small town. There were 3 different urology clinics. They all told her she needed InterStim. She didn't want to do it, but they basically said, if you don't do it, we won't care for you. She felt like she was being pressured into it. I mean, I talked to her. She's like, okay, I guess I have to do it. But she was smart. So she first talked to the insurance claims person in the urologist's office. Is this covered with my health insurance? They've said, yes, absolutely no written pre-authorization is required. She then called the hospital that she was a nurse at. She worked for the hospital, talked to their billing department. They too said, yes, it is covered by your insurance. No written pre-authorization is required. She then called her insurance company and said, "Is this covered?" And they said, "Yes, we cover it. No written pre-authorization is required." The mistake she made, she didn't get it in writing. A week after surgery, she had a threat to garnish her wages for a $55,000 bill. And she said, "I would never have done it. I can't afford that." And they were threatening to garnish her wages. And everybody's like, "Hey, you told me this was covered." Well, yeah, we thought it was covered. So you get in writing from the insurance company that it is covered before you have that surgery. Okay? Because that was heartbreaking and infuriating for that patient. Okay, let's go back. Let me get a drink here real quick. Man, I made this really thick. That's my, you guys, that's my breakfast and lunch. So let's see. Yamo says, "I feel pain too much when I sit, when I sleep, when I feel urination. When I urinate, I feel quite better. That's why I'm standing most of the time." Okay, but Yamo, if you have pain when you sit down that gets better when you stand up, that's all muscle and nerve. That's not your bladder. That's muscle and nerve. Diane says, "I have estrogen atrophy. Will I start to feel better sooner or will it take the whole 3 months?" Well, Diane, I think the question is, what are you doing about that estrogen atrophy? Are you using topical estrogen? When you give that skin topical estrogen, when you give it at your urethra or in your vagina, the skin cells immediately absorb the estrogen, and then it starts to plump up just like a raisin in a glass of water. The cells plump up and they start to produce mucus. So what are we doing about the estrogen atrophy? Because if you're not doing anything about it, you're just going to get drier and drier, and it's going to get more and more painful. And Diane said, "Yes, I had a cystoscopy, no Hunners, but inflammation in the bladder. How about low acid coffee treated with pre-leaf and then diluted by half with cow milk? The pH is 6.7, similar to milk alone." Diane, the question that I would ask you is, if you had an open wound on your hand, would you pour that coffee on the open wound? I wouldn't. I wouldn't. It's really helpful to think of this as an injury rather than an illness. When you think of IC as an illness, remember our AUA guidelines say that there's no bladder disease found in the vast majority of patients. I mean, that's one of the big things that we're trying to clarify here now, is we're trying to let people know that this is not an incurable bladder disease. In the great majority of patients, it is in fact a neuromuscular disorder, usually driven by an injury. So when you think of this as an injury, you go, okay, what can I do to help that injury heal? Well, certainly not pour coffee with pre-leaf and acid on it. I mean, in my opinion, I just think it's important to back off for a while. Give it 3 months, give it 6 months, and then start up again with things that we know are not necessarily going to be that irritating. So I would start first with peppermint or chamomile herbal tea, see how you tolerate that. If you tolerate that okay, then I would go to a brown rooibos tea. Should be fine. If that's fine, then go to an herbal coffee like Dandy Blend, which is our favorite herbal coffee now by far. It's so good. And guys, I got to be real honest here. Man, you know what? I have no shame. I will talk about anything. You know how many times you have a cup of coffee in the morning so that you can stimulate a bowel movement? Dandy Blend. Every time. In fact, I have to pick when I drink it now. Because if I got to go somewhere, it's like, because, I mean, again, I don't know about you, but it's like that hour, 30 minutes to an hour afterwards that, you want to be a little bit close to a bathroom just in case. Anyway, I love Dandy Blend. Okay, so if you do okay with the herbal coffees, then we go to a real low acid, real coffee like Bella Rosa or Tyler's or Simpatico. And we have a lot of low acid coffees over on the IC Network website. That's one of the things that I'm always looking for are really good bladder friendly coffees and teas. Um, so hopefully you'll be able to tolerate those. And if you do, great. If you flare with it, you got to go back to the next step. We call that the IC Network Coffee Challenge. All right, hold on a sec. Jenny said, I had bad burning for 3 months. Urologist did a more sensitive culture called a transplant. Hmm. Culture came back with a 2000 growth of Enterococcus, probably Enterococcus faecalis, Faecalis. Amoxicillin was prescribed, and within 3 days, the burning was gone. All my standard cultures said under 10,000 was negative. Can someone be sensitive to low amounts of bacteria? Absolutely, Jenny. Absolutely. A lot of those, the old kind of standards for urine cultures were developed years and years and years ago. And we've learned a lot now about the biome. We've learned a lot now about different types of bacteria. And certainly Enterococcus faecalis is quite common now in patients with kind of chronic UTI. Let's see, Louise, while I'm in rehab, they have forgotten to administer my estradiol for vaginal atrophy. Yeah. Rehab is tough, girl. I hope you're out soon. I hope you get home soon. Kayleen said they saw the abdominal MRI order was in, which made it so I almost didn't get the MRI. I told them the pelvic is for PGAD and I'd like to get it done today. If I have to, I'll get the abdominal later. The director came back and said the pelvic MRI possibly is reaching the urachal cyst. Yeah, baby. God, I hope so. I hope so. So let me, for people who are new here, I want to share this story. This is a very, very, very important story here. So, you know, one of the challenges that every patient has to understand is that you are an anatomical mystery to be solved. We got to figure out what's driving your pain. Because again, we're to really step back from this vague, incurable bladder disease. We're just not finding a bladder disease in the bladder. And that's what the American Urology Association says. And so when I work with patients, when we do coaching, one of the things that I say is the devil is in the details here. I want to hear about the weird, random, unusual symptom that you might be having. And so, you know, if it's always pain in one location on the left side, then we need to look at the left side and see what structure is on the left side that can be causing that pain. So anyway, Kayleen here, and Kayleen, you disclosed that you're the one with the urachal cyst. So we've made that connection here. So Kayleen and I have I've known each other for a couple of years now, and a few weeks ago she said something that she'd never said to me before. She said, when I push on my belly button, I immediately get bladder pain. And then it goes farther. It goes farther down into her pelvic cavity. It's like a shot, just straight down. Belly button pressure, bladder pain. Well, you know, I'm like going, how could the belly button cause bladder pain? What? I mean, that was just baffling to me. Really, really baffling to me. And I was talking with a OBGYN nurse about it this morning, as a matter of fact. And she's like, she'd never heard of it either. Okay, so it turns out there really is a direct connection between the belly button and the bladder. That when you are a fetus in your mother's belly, how does that fetus drain urine? Well, there is a tube at the top of the bladder dome that connects the bladder to the belly button to the placenta so that urine in the fetus can drain out and the mom's body can process it. There is a tube, it's called the urachus. And normally when you're born, the tube shrivels up and goes away. But in some patients, it doesn't. And guess what? If you have a urachal abnormality, so it is very strongly associated with bladder pain and urinary symptoms. So it can be one of two things. So again, it's a tube. It's like this long that goes from your belly, the belly button to the top of the bladder. And again, it's supposed to shrivel up after you're born. Some people leak fluid out of their belly button. They have a wet belly button. You know what that is? That's urine. And that's one of the things they look for in people with a urachal abnormality is the belly button oozing fluid? It might be a little bit, but does your belly button always have kind of dried fluid on it in some way? Or is it actually wet? Do you feel wetness, moisture? That tells us that your urachus has not closed. But in other patients, it only closes halfway. And so what happens then is urine goes up the tube and it collects there into a cyst. And that is an infectious cyst. And it manifests as a lump by your belly button. And if you push on the lump, it causes bladder pain. So anyway, found a couple of case studies published, gave all the information back to her. She went to one of her doctors who said, wow, yeah, you know what? I think you might actually have this. When I did our meeting 2 weeks ago, and we talked about this, one of our other members shared with me on the phone that he had leaking fluid out of his belly button for 50 years. And then it stopped a couple of years ago, and now he has a lump by his belly button. And when he pushed on his lump, he too had bladder pain that was actually then referred to the tip of his penis. And then still another person in here, in one of our support group meetings, said that when she pushed on her belly button, she got urethral pain, sharp urethral pain. So, you are truly an anatomical mystery to be solved. So if anybody out there has pain in their belly button, our next magazine, our next IC Optimist magazine will be talking about this in depth, because this is completely treatable. And when they remove the urachus, the symptoms resolve completely. And so that's what we're hoping for in Kayleen's case. Crossing fingers, baby, crossing fingers. So does anybody out there have pain in their belly button? Anybody out there have a wet belly button? Lizzie Van, you got to try the Dandy Blend herbal coffee. It's so good. We have it in the IC Network shop. It's really, really good. Lots of patients do it very, very successfully. I have it several times a week. It's solid. John says, how often is pudendal pain caused by pudendal nerve entrapment? Well, John, Chris Payne, when he created a subtyping system, he made it one of the 5 fundamental subtypes that he thought consistently. And now when you look at, for example, if you read this book, Breaking Through Chronic Pain, he believes that there's a lot more pudendal nerve issues and nerve entrapments going on in the typical IC and pelvic pain patient than many people realize. I think, our fundamental flaw here is that Western medicine fails the typical IC patient, as he writes in his introduction, because doctors stay in their sandbox. Urologists assume it's a problem with the urinary tract. Gynecologists assume it's a problem with the reproductive tract. Gastroenterologists assume it's a problem with the gut. But as he argues, pelvic pain is about relationships. It's about things that influence those organs. And what influences those organs are muscles and nerves. And if those muscles are screwed up and reducing blood supply, then that's going to affect the organs and that's going to affect the nerves, because the nerves need good blood supply to function and be healthy. So I think it's a what do they say? 85% of IC patients are neuromuscular in origin. So I think it's a big chunk of patients who potentially have a muscle nerve compromise, whether it's an actual direct entrapment, whether the muscles have gotten so tight they're now physically restricting that. It's probably a smaller group of patients, but I think most of us have nerves that are compromised by tight muscles. Peggy says, he's been on PEA 500 for 3 months. I believe it's helping. How long can you take it for? Well, the studies are inconclusive. My approach with PEA, palmitoyl ethanolamide, I've been using it off and on for 3 years now. I have found it remarkably helpful for my nerves. I don't take it consistently, though. I'll take it for a month or two, and then I'll stop it for a month. And what I have found is that it's durable. When we say durable, it means that even when I'm off the medication or when I'm off the supplement, I still have a beneficial effect. But that tends to be the way I personally work, is I want to try something and then I want to get off of it and I want to see if it still helps. And so my approach to PEA is I'll do it for a couple months and then I'll stop it for a month. And once I feel my skin getting funky again, I'll usually start it again. Val says, what do I think about the Microgen test? I'm a strong supporter of next generation DNA urine testing. It is data. It is hard facts. I've worked with that company for several years, off and on. I'm not working with them right now, but I have for years. I think that there's a lot of emotionality attached with cold. I mean, you got to understand here. There's industry influences here. Hospitals, health insurance companies believe that the best way that you can test urine is with a typical urine culture. It's cheap and it's fairly effective. The problem with a typical urine culture, the word culture means you're trying to grow bacteria. How do you grow bacteria? With food. We call it a medium. So when you do a urine culture, you're only growing out the bacteria that eat the food you're giving it. And so cultures are self-limiting. Cultures can miss many, many, many different types of infections. Next generation testing does not miss that testing. I mean, it does not miss to the same degree that a culture will. But the other great advantage of next generation DNA urine testing is it will also identify fungal infections. And it's our own U.S. National Institutes of Health, the big IC research team at the MAP Research Network, who found that many IC patients who were struggling with very painful bladder wall flares actually had active fungus growing in their bladder. And this shouldn't come as a surprise, because if there's any group of patients massively over-medicated with antibiotics, it's a lower urinary tract patient. Remember, fungus is normally controlled by good bacteria. But if you're one of those patients, every time you flare, you pop a couple of antibiotics that you keep in your bedside table just in case, and you don't wait for that urine test, you just go ahead and you just take it, you're creating a very dangerous situation because whenever you take those antibiotics, you're killing your good bacteria, which is going to open you up to uh, really difficult candida infections. We have candida glabrata, which is very drug resistant now. I know this because I had it for 2 years in my bladder, and I got to tell you, it's agony. See, guys, 20 years ago, 25 years ago, we were all assuming that we all had infection. And yes, there are people online right now who are still saying we all have infection. Okay. But back then, it was led by a Dr. Paul Fugazzotto, who did something called a broth culture. He found enterococcus in my urine, enterococcus and micrococcus in my urine. And the recommendation back then was you do long-term antibiotics. So I did Augmentin for 6 months. At the same time, I was sitting on a heated chair cushion. You put heat in an area with fungus, it's going to grow. And I ended up cooking myself up a very, very drug resistant Candida glabrata infection in my vagina, in my vulva, but more importantly, inside my bladder. And I'm going to tell you right now, that was the worst pain I've ever experienced. It was so much worse than typical bladder wall pain. And so next generation DNA urine testing can rule in or rule out pathogenic bacteria and pathogenic fungus. And I think last but not least, what I would say to you is that there are many, many patients who just every time you flare, you're going, I have infection, I have infection. Because you don't understand that the bladder only has two sets of nerves to tell you there's a problem: the frequency urgency nerve and the pain nerve. So everything feels like infection, everything. A bullet wound would feel like infection. A stab wound would feel like infection. A chemical injury of the bladder from diet soda will feel like infection. But some of you are like, no, it's infection every single time. And I say, prove it. Have a next generation DNA urine test. I was working with a patient not long ago who refused every treatment. All she wanted was antibiotics. And she told her doctors, I don't believe you. It's infection. It has to be infection. And she refused every treatment. The only thing she wanted was antibiotics. And they wouldn't give them to her because her cultures were negative. And so what I said to her is, I said, okay, prove it. Have a next gen test. If it comes back with no pathogenic bacteria, they're right. And you don't have infection. And it's time for you to look beyond antibiotics as a treatment, but more importantly, beyond your bladder, trying to figure out why the hell you're in pain in the first place. But if that next generation test comes back with a funky infection, then you've got all the ammunition you need to go to your doctor to say, hey, yeah, I think here it is. Here's the proof. I have infection. I want treatment. And the advantage of a next generation test is not only do they identify the bacteria all the way down to antibiotic resistance genes, but they're also going to give you treatment recommendations for whatever they find. So it's data. Now, the fundamental flaw with next generation testing is that the data is very hard to interpret because there's still so much we don't know about the urinary biome. And so I interviewed the CEO of a Microgen several years ago. And I said, okay, here we have a patient, asymptomatic, IC is very controlled. She has a next gen test and she finds something funky in there. Do we treat it? And his answer was no. You only treat if the patient is symptomatic. So some patients like to you chase bacteria. First they find one, then you kill it, and then they find another, and you kill it, and then they find another, and you kill it, and you feel like you're stuck in this loop. And what he said, as I asked him about that, he said, you always focus on the combination of the results with the actual symptoms. Because if that patient is asymptomatic, if the patient is having no urinary symptoms, there's no reason to take antibiotics. We don't want, and again, remember, your biome is this lush garden of good bacteria, bad bacteria, etc. And we don't want to disrupt that garden. We don't want to take a flamethrower to that garden and kill everything. That would be that is devastating. I could go deeper into that, but and get really geeky with you, but I won't right now. Julie says fallopian tubes give pain too. I had to have them removed. They were inflamed. Interesting. I wonder why they were inflamed, Julie. Jenny says, does D-mannose only work on E. coli? I seem to get enterococcus when I do get infections. I don't get them often, though they told me all cultures are negative for 3 months till the transplant culture was done. So maybe I'm getting infections more and I don't know it. What can I do to prevent recurring UTIs? Jenny, actually, we were just talking about this on Thursday and Friday. It's the combination of D-mannose and PACs, proanthocyanidins, that is going to be the most effective at preventing multiple types of infection. And so the one that I'm dressed a little funky today, guys. Sorry about that. It is what it is. It's a Sunday. Okay, so what research has shown is that proanthocyanidins are more effective than D-mannose at preventing recurring infection. But it's a combination of proanthocyanidins and D-mannose that are the most effective. And so there are two products on the market that get the best reviews for this. One is called Ellura, Ellura. Ellura is very popular. Unfortunately, it's very, very expensive. It's like $120 a month. So the second one is called Prevent, PRVNT, and it's actually a stronger formula than Ellura at half the price. And this is what we have in the IC Network store, because this is the same company that makes Bladder Builder and Bladder Rest. This is a company that we closely work with. So I would consider trying a PAC product. And the thing too is, you say you're taking Eucora, but are you still getting infections? If you're still getting infections, the Eucora is not working. I'm not a Eucora fan myself. Heather says, I get a bacterial smell from my belly button, but I don't feel bladder pain when I push on it. I have tried antibiotics and it never seems to go away. Isn't that interesting, Heather? That's fascinating. So could you have a little remnant of your urachus behind your belly button that's just a little source of infection? It's possible. Peggy said, going to have steroid injections in my SI joints. Just read where inflammation of the SI can cause pelvic pain and pressure because they are very well connected. I'm hoping that this is why I'm having pelvic pressure plus the hip and sciatica pain. Yeah, I've had steroid injections in my left SI a couple of times. I probably do again. Loretta says, is there a gland that can fill with fluid in or near the urethra? I think you spoke about this before. It's about a pea size. I feel it during the pelvic floor. I feel urgency. By the way, having a bear of a time getting compounded estrogen. No one in my area seems to want to be bothered and won't write a script. I'm ready to scream. Loretta, I'm so sorry. Yes, you're referring to the periurethral gland. It's basically the female prostate gland. It is a homologue to the male prostate. The tissue is identical to a male prostate, much smaller, but we do indeed have a little prostate gland about halfway up our urethra that can fill with fluid and become infected. Oh, it's the very first article I put on the IC Network website when I built it in 1994. Was an article from UCLA on the periurethral gland. Diane says, I see differing opinions about daily antibiotics, but my doc feels it's important. I take a probiotic with it. What's your opinion? Well, Diane, there's two two distinct opinions. And again, I was at a UTI class Friday morning. And they, flat out said there are some women who struggle with recurring UTI who do benefit from a antibiotic, preventive prophylactic antibiotic. The challenge is that you are disrupting your biome when you're taking that antibiotic consistently over and over and over again, which many believe leaves you more vulnerable to drug-resistant infections in the future. I look at it a little bit differently, Diane. I would want to know, to me, the most important question is, why are you vulnerable to infection? Why are you vulnerable to recurring UTI? And generally, that answer goes right back to the quality and health of your skin and your estrogen levels. Think about your bladder for a moment. Yeah, and Angel, yes. Think about your bladder for a moment. The bladder is the only organ in the human body designed to hold toxic waste. So how can the bladder hold ammonia for hours and hours at a time and not get damaged? It's a fascinating evolutionary adaptation. Well, it turns out the way your bladder defends itself is just with a really thick, robust coating of mucus. It's wet on the inside. Your urethra is wet on the inside, just like your vagina and your vulva. And this mucus is a barrier. It plays a protective role. It protects the skin from whatever's in your urine, whether it's an irritant or whether it's a bacteria. Bacteria basically have to chew through. I mean, they don't have teeth, but they have to penetrate through the mucus to reach a cell to infect the cell. So this mighty mucus is essential to the structural integrity of the bladder wall. Unfortunately, it is also estrogen dependent. So when you're young and have lots of estrogen, you've got lots of mucus. But if you're on birth control that's suppressing estrogen, if you're on Lupron to put you into an early menopause, or if you're just in perimenopause or menopause, and the older you get, the less estrogen you get, the thinner the mucosal barrier gets. Your skin begins to dry. You're losing that nice coating of mucus. And so if you are, so what the research has shown, and I got this from a class that I took. I don't remember. No, it's the Anthony Schaefer class. Was it the Anthony Schaefer class? Anyway. Okay. That 24 hours before the bacteria arrives in the bladder to infect the bladder, it's living in the vagina. So this then led the UTI researchers to ask, well, what's happened to my vaginal defenses? Why has my vagina become a safe haven for bacteria? And the answer goes right back to estrogen atrophy. So, and this was the Anthony Schaefer lecture, because what he said is, if you've had 2 infections in 6 months, 3 in a year, you are a recurring UTI patient. You are a complex UTI patient. You would never be diagnosed with a simple UTI. This is a complex UTI. And generally, in addition to taking the proper antibiotic, they would also normally give you a topical estrogen to use vaginally to boost the health of your skin and your vagina, and to improve the quality and health of your skin everywhere, so that you will not be so vulnerable to infection. I hope that makes sense. So Angel said, can lack of estrogen make you itch? Yes, it can. It's very, very common for a perimenopausal or postmenopausal woman to develop very itchy skin, because the quality and health of that skin is changing with the lots of estrogen. Diane said, I've been using estrogen cream for over a year now. It has helped a lot. And in pelvic floor physical therapy, that is helping. Is dandelion okay for the 3 months I'm following the IC diet, or just water and cow's milk? I think it's okay. I think it's okay. I mean, there's no acid in it. Jenny said, yes, she's still getting infections on Eucora. When I started the Eucora, it helped my IC symptoms of urgency and burning, so I kept taking. Yeah. Val, thank you so much for the 200 stars. Really, really appreciate it. You guys, if you find these meetings helpful, please think about becoming a member of the IC network or at least joining our newsletter. I've got over 20,000 patients who read my newsletter. I'll be sending out a newsletter again this month, maybe in the next week or two. So come on over to the IC network and sign up for a free newsletter. Or if you're on Facebook, you can do it right here on Facebook. And or come on over to the IC network and think about, buying something in our shop from our book, IC 101. It's not just a bladder disease to a chair cushion or heating pad or low acid coffee. Or yes, indeed, some of the supplements are in our shop too. Loretta says, how to prepare urethral gland diagnosed and treated? Very easy to diagnose it because it's a lump you can feel about an inch into the vagina. If they feel a tender lump, it's like a deep pimple. Then that usually means that you have an infected gland. And the way it's treated, it's awkward how it's treated because generally these bacteria are in biofilms inside the gland. And there's lots of different bacteria that can be inside the gland. I mean, I've worked with patients who have had these. So basically, usually what the doctor does is they'll have something in your urethra and they'll have a finger in your vagina and they press on the infected gland to try to express the fluid out. Then when they express the fluid out of the urethra, they culture it, and that's where they can find. The last patient I worked with was several years ago. They were shocked at how many different bacteria were in this pus inside this infected gland. Sue said, for 40 years, whenever I have a flare, I get swollen glands in my groin. I've only had a couple infections in my life. What would be causing my glands or lymph nodes to swell in my groin without having an infection? And no doctor's ever answered that question for me. I don't know if you would know why. That happens to me too. I can definitely get a swollen gland kind of right at the top of my leg, in between my leg and my pelvis. And that happens to me when I have a cyst. Have you ever had a little pimple like on your skin down there on the vulva, somewhere in there? I find that they're caused by friction, sometimes by toilet paper. If you wipe really hard, you kind of break the skin and it becomes the equivalent of a pimple. I've had, when was the last time I had one? I usually get one or two a year, maybe one a year. But every now and then you get a whomper. And it can get big. It can get like the size of a cranberry. And that, and so what I have done when I feel it, and sometimes they just pop on their own, and the only way you know is when you wipe after you urinate, there's a little streak of blood and a little streak of pus. I just squat over a mirror. So in my bathroom, I've got drawers. So I just pull out my top drawer. I put a mirror on top of it, and then I just step over it, and I use the mirror to look at my skin down there. And they're really easy to see because they're just oftentimes you can see the head of it, and sometimes you can squeeze it and pop it. And sometimes, occasionally, if it was really, really painful, I would use a needle to try to pop it. But I will tell you, Sue, pretty much every single time I've had one of those, I've gotten a swollen gland in my groin. Long story. Jacqueline, Jacquelina, I don't know if I pronounced your name right, but thank you so much for the 99 stars. I really appreciate it. Really, really appreciate it. Thank you so much. Really appreciate it. All right, let's go back here to YouTube. Yamo says, thank you so much. You're very, very welcome. Zara wrote something and then she retracted it. So Zara, please, I'm welcome to every question about IC and pelvic pain. No topics are off are unwelcome. I'll let you know. So please ask whatever it is you wanted to ask. Janet said, I have been prescribed topical estrogen twice. Both times it makes me hypersensitive and irritated on the outside of my vagina. I still use Evamist, which is a spray estrogen. It's expensive, and I tend to use it every other day rather than daily. After listening to you just now, I better not do that. Well, Janet, the reason why estrogen can be an estrogen cream can be irritating is because your skin is very, very dry. Remember that mucus plays an important protective role. It's a coating, it's a barrier. The challenge is that many women wait too long to use before they try estrogen, and their skin gets very, very dry. So there's not a lot of protection there. And so anything you put on that dry skin has a chance of burning and becoming sensitive. That's very common. In fact, I used my estrogen last night and it burned a little bit. It burned for like 20 seconds. But back when I started using my estrogen, it burned for a couple of hours before it calmed down because my skin was very, very dry. The advantage of the estrogen is that your skin immediately absorbs it and starts to produce mucus. And so the burning should get better and better and better. Usually it takes about 2 weeks to go from the burning stage to it feeling like a warm puff of air, and there shouldn't be any discomfort. There are some formulations of estrogen though that can cause more irritation. If brand names like Premarin or Estrace have preservatives in them to extend shelf life, sometimes you can react to those preservatives, or you can react if there's alcohol in it. And so for patients who are sensitive, who have that burning sensation, don't be afraid about the burning. You have to ride through it again, the 2 weeks often. But if the burning hasn't resolved in 2 weeks, then you may be having a reaction to something in it. And that's where you can go to a compounding pharmacy and get a preservative free formula. The compounding pharmacy that I use is the Women's International Pharmacy in Arizona. They don't pay me to say that. It was my own doctor, Dr. Bennett, who said, Jill, we already know you're very, very sensitive. I'm not going to waste any time with brand names. I'm sending you to the best. And he sent me to the Women's International Pharmacy, and I have had tremendous success. Every woman in my family now uses them for their estrogen. Good stuff. Sue says, okay, this is embarrassing. I'm sure a lot of women out there probably have the same problem, and we're free to talk about stuff here. I had a labiaplasty, which my insurance covered for a long time. I had a lot of cysts on that side, and the doctor, hold on a second. The doctor thought it could be contributing to some of my painful condition of my skin down there. A lot of women are born with one side of the labia bigger than the other, and it can also affect getting good. I'm not quite sure what you mean there. I was always too embarrassed to talk about it to any doctor, and the surgeon, when doing the hydrodistension and Botox, asked if she wanted me to me to remove the cysts and also possibly get approved for a labiaplasty on the left side. But as far as infections, Hun, I'm sorry. I mean, it's as far as the infections during when I don't have that cyst that you always get them when you have flares. but I'm happy that my insurance covered that surgery. It was something I felt affected my confidence. Didn't even know it was a thing with other people. It's actually very common. I hope this checks it out right. She says all the horseback riding that she did definitely made that condition worse with the cyst. Yeah, definitely. Zara says, what's your opinion on how successful high strength antibiotics are for embedded UTIs together with Hyprex? Thanks for all your help. I'm on this and considering the next gen testing. Well, now, didn't you ask the question? So again, I attended a class on UTI and pelvic pain Friday morning. Um, Back in the old days, back in the 1990s, before social networking, we had internet news groups and we had websites and we had AOL and CompuServe. That's it. And back then, people were saying UTI, UTI, you have an embedded UTI. Well, and they were very, very rabid. I mean, we're talking offensive, insulting. You're stupid if you're not on antibiotics. Really. And then I had somebody in the IC Facebook group that we had back then say everybody should be on antibiotics. Antibiotics are safe for everybody. And I had to go in and say it's absolutely not true. Everybody has different sensitivity. So this is a message that we've been battling for many, many years. Um, so, Zara, last year at the American Urology Association meeting, we had an absolutely fabulous, fabulous course on IC that was taught by Dr. Ann Ackerman at UCLA, along with two other doctors. Henry Lai, I think, was one of them, and Dr. Ann Ackerman. Dr. Ann Ackerman is like a future Nobel Prize winning biome specialist. This is a woman who is incredibly talented at finding funky infections. And so now that we have next generation DNA urine testing, we've had that for a good 8 or 9 years, they can identify everything that lives in the bladder, good bacteria, bad bacteria, fungus, etc. And we have had a number of research studies over the years looking for that elusive bacteria that could be the cause of infection. And all of those studies came back with nothing. They were hoping that they would find something like Helicobacter pylori, which we now know causes stomach ulcers. And that was a big, big deal back then, because back then they didn't think that bacteria could live in the acid of the stomach. Now we know it can, and now we know that stomach ulcers are caused by this Helicobacter pylori. So they were hoping that they would find something like Helicobacter pylori in the bladder. They didn't find it. And in fact, of these multiple studies, the biome of the IC patient was normal, a little bit less diverse than normal, though. There weren't as many different types of bacteria. And there was an overabundance of lactobacillus, good bacteria. So this really intrigued Dr. Ackerman, this absolutely phenomenally talented researcher. And so she decided in her lab at UCLA, or maybe it's USC. Anyway, she decided to study this. No, UCLA. She decided to study this. And so she brought in 80 or 90 patients, did her testing, and her initial conclusion was, wow, totally normal, a little bit less diverse, not as many different types of bacteria, and an overabundance of lactobacilli. So her research did not find these embedded UTI, et cetera, et cetera. What these studies consistently find is that we have a normal biome. But the next thing she did is she applied that to our phenotyping system. And that's where a brand new discovery was made. So if you don't know what phenotypes are, these are the groups of patients. So we separate now. We don't just tell everybody they have an incurable bladder disease. We have to figure out what group they're in to find the right treatment. And so the researchers use 3 groups instead of the 5 that we use. They go for bladder-centric, pelvic floor-centric, and or pain beyond the bladder. So there's 3 groups there. So when she looked at her data on that, she found completely normal biome in patients with pelvic floor dysfunction. Nothing wrong with the biome, no infection at all. In patients who had pain beyond the bladder, they were dominant in E. coli. But for patients in the bladder-centric phenotype, they were dominant in something brand new called Lactobacillus iners. So again, not a biofilm. I mean, not an embedded infection. So Lactobacillus is, quote, a good bacteria, right? Lactobacillus plays an important role in controlling fungus, in kind of maintaining the status quo of a good, healthy ecosystem. Lactobacillus crispatus, patients who are dominant in Lactobacillus crispatus are associated with having a very good long-term outcome. Patients who are dominant in Lactobacillus iners, INERS, were associated with having a poor outcome. So if you were a bacterial vaginosis patient dominant in Lactobacillus iners, this was going to be a very difficult situation. So the question then is, what the hell is Lactobacillus iners? I thought Lactobacillus is good. Well, they only discovered Lactobacillus iners a few years ago when they started using blood to try to grow out bacteria. That's when they made the first discovery that there was this new, different species of lactobacillus called Lactobacillus iners. Lactobacillus iners does not behave like normal lactobacillus. It actually behaves like a pathogenic bacteria. It dominates the biome. It does not control fungus. And most importantly, like a proteus infection, it actually damages cells. It damages cells. So again, Dr. Ann Ackerman found Lactobacillus iners in patients within the bladder wall subtype consistently. So then the question is why does Lactobacillus iners become dominant? And I did some, because I wrote a big article on this a year ago after the class. It's in our magazine. Lactobacillus iners is an opportunistic infection that is very quick to grow and populate the biome after antibiotics are used. So it's like a weed. You know, what's the first thing that grows back when you turn soil to grow something? The weeds grow back. Lactobacillus iners is kind of like a weed. It's very, very quick to grow, and it grows in quantity, and then it consumes all the resources so that the good lactobacillus, like Lactobacillus crispatus, cannot grow. And so that is indeed the latest info on the urinary biome in the typical IC patient, and it does not support the concept of an embedded infection. Instead, it may be the overuse of antibiotics that have contributed to the growth of this damaging Lactobacillus inert. Now, the next AUA conference is the first week of May. And let me just check it. Hold on a sec. Let's see if she's going to speak again because she's so good. You know, the conference is in San Antonio, and a lot of people are not going because, especially if you're pregnant, you don't want to go to Texas if you have a problem with your pregnancy because you might not be able to get the care you need. So a lot of people are protesting and not going to the conference this year because it's in Texas. Let me see. Let me just check. There's a part of me that just wants to buy a ticket and fly down there. Last minute, I might. I'm kind of thinking about it. Let me see if she is presenting. They still have not updated the website. No, they have not. Anyway, you know what? Hold on a sec. Let me do this. Let me go to the National Library of Medicine and let's see if she's published anything recently. I mean, she's absolutely brilliant. Cannot wait. I mean, there are some people you just have to go hear, and she's one of them. Oh, isn't this interesting? Antibiotic switches and UTI are associated with atypical symptoms and emergent care. That was published last month. Let's see what that's all about. Okay, given the worsening global antibiotic resistance, antimicrobial stewardship aims to use the shortest effective duration of the most narrow spectrum effective antibiotic for patients with specific urinary symptoms and laboratory testing consistent with UTI. Inappropriate treatment and unnecessary antibiotic switching for UTIs harms patients in a multitude of ways. So in this study, 908 encounters during July 2019 for patients with UTI in a single healthcare system. 64% received antibiotics, 86% of which were empiric. Of the patients given antibiotics, 89 of the 15% were switched to an alternative antibiotic in 28 days. Emergency care settings and positive urine cultures were significantly associated with increased antibiotic switching. Patients subjected to switching tended to have higher rates of presenting symptoms inconsistent with UTI. Well, isn't that interesting? Oh, hold on. What's this one? No. I mean, I think she's brilliant. Wow, a lot of research published. I'm gonna have to go through this. Maybe I need to try to get an interview with her. All right. So anyway, that's a long answer to your question. And in my opinion, what we have to do is we have to wait for more information on lactobacillus sinus to see what role, if any, that is playing in patients with resistant UTI, and how taking antibiotics over and over again just kind of seed the grounds to make it even more dominant. Okay. Jenny said, I looked at Prevent and see it has cranberry and vitamin C. I'm food sensitive. So are those ingredients? The formula of Prevent is very low acid. And so it usually doesn't bother IC patients. Rarely does. Every now and then it might bother some people, but for the vast majority of patients, it's very bladder friendly. Sue said, I had the same thoughts when they discovered bacteria in the stomach that maybe it was in my bladder that before the subtypes. Yeah. Carolyn said, what food or drinks irritate a weak vaginal wall? Well, food or drinks do not influence the vagina because foods don't pass through the vagina. So the foods are going to pass through the bladder. And that's why the bladder wall can get irritated if you are drinking diet soda or coffee or you're eating something hot and spicy. So the only thing that can kind of answer that question, oh, honey, oh, hold on one sec. I've got another marketer in the Facebook chat. All right. So in vulvodynia, which means that you got pain on your vulva or pain on your labia. So we've got very sensitive nerves that are triggering, you feel like you have a yeast infection, even though you don't have infection. Foods that are high in oxalates can be irritating to the bladder, the urethra, but more importantly, the vulva. And so some women who struggle with vulvar pain feel better when they reduce symptoms, foods that are high in oxalates, like chocolate and berries and spinach. So that's kind of like the only thing I can correlate with your question. Zara Ackerman, A as in Anne, L as in Lenore, Ackerman, Ackerman. So if you go to the National Library of Medicine, pubmed.gov, do Ackerman AL. Ackerman AL. Sue said, how is it possible that you can feel pain in your bladder within 10 minutes of drinking or eating certain foods? You would think it would take much longer for it to get down to your bladder, but a half a glass of wine in 10 minutes, I'm in pain. You know, honey, I don't know. That's a really good question. I can think about like probably one of the absolute worst bladder wall flares I ever had was when I was dating my boyfriend Todd, and we went to see a Harrison Ford movie with some friends, and I got a soda fountain 7-Up. When the can of 7-Up, it was where they make the 7-Up from the syrup, and it was really strong. And it just destroyed me. And I think that I was in agony within 30 minutes of drinking it. And all I remember is just constantly getting up to go to the bathroom, him going, what's wrong, Jill? What's wrong, Jill? And then me at the end of the movie, I just ran for my car and I cried all the way home. It was so bad. He was so baffled. He's like, what is wrong with Jill? I bet 10 minutes, and I mean, you're right, urine does not get to the bladder in 10 minutes, it doesn't. So I'm not sure, hon, I'm not sure. All right, guys, well, we've been going now for about 2 hours, so, I'm here to answer questions, and when you're done with the questions, we can call it, or if anybody wants to go into Zoom and have a chat with me, that's fine too. We can always transition into a Zoom meeting. So you're slowing down with your questions, which kind of means that maybe we're coming close to the end. So, are there any other questions out there? Because if not, I'm going to go back into my garden and plant some flowers. Sue says, "Is it just me literally, sometimes less than that?" No, it's not you. I mean, the only other thing I can think of is that you might be anticipating the pain and tightening your pelvic floor muscles. And as you tighten those pelvic floor muscles, you squeeze the blood vessels, and that can trigger the pain too. Are there even any good movies out right now? Has anybody seen a good movie recently? That's something else I could do. I like going to the movies alone. You know why? Because it was a totally an IC thing. It was that I didn't want to be dependent on somebody else to drive me home if I had a flare, and I always felt bad if I had a flare and I had to leave, and that was directly from the Todd experience. So what is even playing right now? Blood for Dust, a crime thriller, Hard Miles, a drama, Housekeeping for Beginners, that's a comedy. La La Chimera, I don't know what that is. Looks like a foreign film. Civil War, science fiction. Wicked Little Letters. Ooh, that looks like a British one. I would probably like that. One Life with Anthony Hopkins. Hmm. Wicked Little Letters. That's interesting. Oh, it's in 45 minutes. A 1920s English seaside town bears witness to a dark and absurd scandal in this riotous mystery comedy. Interesting. Gina said, everyone talks about the pain like a sharp pain. I always get aching feeling. Could that be bladder wall pain or pelvic muscle pain? That's pelvic muscle pain usually. It's muscles that ache and burn. The bladder wall pain tends to be really sharp. Bladder wall pain feels like razor blades. I mean, it really hurts, whereas muscle pain is duller and achier and it has a burning sensation to it. Zara says, how do I find out if I've got the lactobacillus sinus? Do I have to do a urinary microbiome test? Honey, this is very, very early research. They're not even looking for it in most patients right now. It's only being done in her lab. So there's no way. I think the message here is that she did find something a year ago, 2 years ago, and now we're waiting for additional information on that. I think I would what you should do is Google Lactobacillus sinus a little bit to learn a little bit about it. Um, and again, this is that very difficult area of the overuse of antibiotics. So why have you been taking antibiotics for 14 days? Generally what they say if you have an acute infection is you take a narrow spectrum antibiotic that we know will kill that specific bug for the shortest period of time to minimize trauma and change to your biome. So it's preliminary, hon. It's just preliminary. As soon as I get more information, I will let you know. But right now, you could go to our summer of 2023 magazine to read more about her research. So what would I do is I would make sure that you're repopulating your body with good bacteria. If you have to be on antibiotics, what do they say? Make sure you're on prebiotics and probiotics to try to reestablish and repopulate your body with the good beneficial bacteria. Gina, she aches and burns. She said, they said my pelvic floor was not tight. The muscles were healthy. Could it be nerve related? It could be. Gina, can you be a little bit more specific on where exactly is the burning pain? Is it on the skin, on the outside, or is it inside of your body? So, where exactly is the pain? External or internal? Anne says, you were telling someone to look something up. I missed it. Sorry. Jenny said, thoughts on Theracran. I saw it has less ingredients than the Prevent. It's the combination of the PACs and the D-mannose that has been found to be more successful. So let me look up Theracran. I'm not sure what's in Theracran. So it has PACs in it, and it has cranberry extract, but it does not have the D-mannose. So that's a PAC product, but not a D-mannose product. So it's the Allura or the Prevent that would make a little bit more sense based upon the research. Anne says the internal burn, what is it? That internal burn, it depends upon where the burning is inside. Is the burning in your urethra? Is the burning in your vagina? Is the burning in your rectum? Or is the burning in your bladder? Where is the burn? Muscles that are working hard produce lactic acid that causes the burning sensation. So concept number one is it's muscles that are working hard. Remember when you were a kid at school and they'd make you run around the track, and as you ran, your legs would start to burn? That's what muscles that are working hard do. They burn. They produce lactic acid, which burns. So concept number one on that burning sensation is pelvic floor muscle. Concept number two on that burning sensation is the quality and health of your skin. The quality and health of your skin. Burning is common when your skin is dry because of estrogen atrophy. Jenny says, I have D-mannose in Eucora, or I have D-mannose powder. Did you just delete that? That was weird. I saw it and then I didn't see it. So Anne says vaginal burn, that's usually estrogen atrophy or bacterial vaginosis for that vaginal burn, or it could even be a candida fungal infection. Gina says inside like a headache in the pelvis. So Gina, you have to really try to be a little bit more specific. Inside where? Again, is it on the left side? Is it on the right side? Is it in the front? Is it in the back? Where is the burning? Diane said, are blueberries okay? Yes, blueberries are definitely okay in the IC diet. Gina said, I was not diagnosed with fibro, but I think I have it. I had jaw pain, I had irritable bowel, I had hip, low back pain, and a keen sense of smell. Gina, that puts you in the widespread pain subtype with me. So the widespread pain subtype or patient or phenotype are patients who have multiple pain conditions, IC and or IBS and or vulvodynia and or TMJ and or migraines, et cetera, et cetera. And it's characterized by having very sensitive skin and a wicked sense of smell, that you can smell things that other people can't smell, and smells actually trigger pain. So, what is that? Well, we have a fabulous research team called the Chronic Pain Research Alliance, and they're the ones who made the discovery that all of these pain conditions are actually being driven by the central nervous system, specifically a central nervous system that is stuck in fight or flight. The 24 hours a day, 7 days a week, patients who have multiple pain conditions, their brain is behaving as if their life is at stake. Fight or flight is not meant to be long term. It's meant to be very short term. It only happens when your life is directly threatened. If you woke up and if you opened your front door and you saw a tiger, believe me, you're going to go into fight or flight. But it's 2024. You don't have to worry about the tiger chasing you and eating you. You just shut your front door and you call the authorities. They come out, they trank the tiger, they take it away. An hour later, the tiger's gone. Press might be there, but the tiger's gone. 2 hours later, 3 hours later, the threat's completely gone. And that's when you're supposed to go out of fight or flight. And the parasympathetic nervous system retakes control of the central nervous system and calms everything down. It lowers your heart rate, it lowers your blood pressure, and it relaxes your muscle. But that's not happening in patients with widespread pain. They are stuck in fight or flight. So the question is, why did that happen? I was stuck in fight or flight for decades. Well, for 80% of the children who develop widespread pain, there's a history of a major injury in childhood, like being hit by a car, broken leg. I fell and broke my tailbone in 7th grade. That's when all of my problems started. So we know that 14 days of pain will put the brain into a constant state of fight or flight for which it struggles to get out of. But for the other 20%, it's a history of abuse or bullying. And so think about that child who grew up with a violent alcoholic parent. That child's safe place was at school. But as soon as school got out and they had to walk home, you can damn well believe that their brain went into fight or flight. And the closer they got home, the more scared they got. When mom or dad finally came home and started drinking, believe me, they became very, very hypervigilant and they were extended fight or flight. Dreading mom or dad getting drunk and hurting them. I've worked with tons of patients who grew up with alcoholic parents. So think about what that does to that brain of that child. They've been habituated into fight or flight legitimately because their life really was at stake because they had an abuser in their home. It's so sad when that happens. And I've shared that I grew up in a neighborhood with a guy who raped and murdered my neighbor. And I was attacked in 4th grade. That also played a role in my symptoms. And I was in fight or flight from 4th grade until about the age of 35. Thankfully, I took a class that taught me how to get myself out of fight or flight. So the good news here is that, well, how do we know you're in fight or flight? Anxiety. How many of you say no to every single invitation? Hey, Jill, you want to go to the movie? No. I'll have to get up and go to the bathroom. You want to go out to dinner? No. It'll flare me. You want to? No. Why do you say no all the time? That's the brain in fight or flight. The brain's trying to protect you. It's trying to keep you home where you're safe. I've asked a lot of researchers why my brain did that because I wanted to accept every invitation. My brain said no every single time. Why? So annoying. So as scary as that sounds, there's really great news here because we know exactly what to do for these patients now. That if we can get the brain out of fight or flight, and it's really quite easy to get the brain out of fight or flight, the entire nervous system calms down. And as the nervous system calms down, they get less sensitive and the pain goes away. I don't have IBS anymore. I don't have migraines anymore. I have TMJ, definitely, but that's more structural from working at the computer and having scoliosis. But my IC symptoms are basically gone. My IBS is gone. My vulvodynia is gone. They're gone now. Why? Well, number one, I've worked with my muscles because my muscles were so screwed up from me breaking my tailbone. And I have calmed my central nervous system and I no longer live in fight or flight every day. So that might shock you, but that's exactly that widespread pain subtype. And it's fantastic now. Now we know why these patients are suffering. And now we know why typical bladder treatments are not effective. Because we have to target the central nervous system. And if we get that central nervous system out of fight or flight, things start to improve dramatically. Jenny said, blueberries make me burn. All fruit does. It's so weird because I'm definitely pelvic floor type, but maybe another type too. Well, Jenny, the reason why patients who are pelvic floor driven get bladder sensitivity is because those muscles are so tight, you're in a state of ischemia. So as those muscles get tight, they squeeze blood vessels, and that starts to restrict blood supply to the bladder. So if your bladder is only getting half of the amount of blood it normally gets to be healthy, will you have a healthy bladder wall? And the answer is no, you won't. But for these patients, you can throw bladder therapy, I mean, come on, I did bladder therapies for decades. It never worked for me. Why? Why? Because I have a healthy bladder. It was never my bladder. It was always my tight muscles and my nerves. So bladder therapies will not fix the underlying problem because the underlying problem is actually diminished blood supply from very, very tight muscles. That's why physical therapy is a priority for that pelvic floor patient because our objective here is to restore good blood flow. And we do that by relaxing muscles. And so those food sensitivities go away as the bladder wall gets healthy again. I can eat anything now. I drink lemonade almost every day. I didn't drink lemonade for 40 years. I can drink lemonade now, or 30 years. And I do drink lemonade almost every day. Anne says, what is burning inside the urethra? That's usually estrogen atrophy that has dried out that skin. So the urethra is the canary in the coal mine when it comes to estrogen atrophy. It's the first part of the urinary tract that can start screaming in pain. And that's what happened to me. My urethra got very, very irritated when I was about 52. And I threw, oh, that's a squirrel again. He's looking down at me from the house next door. Hello, squirrel. Oh, now he's jumping up on my roof. It felt like there was a drop of urine stuck in my urethra that won't come out. And my urethra got very, very, very irritated. And as my urologist said to me, he said, Jill, that's very common with estrogen atrophy when that's like the first sign that you're really entering those bigger stages of estrogen atrophy. And so he prescribed me estrogen again to rub at the entrance to my urethra. And once I started doing that, I got better, lots and lots better. Lori says, help me know how to make a better bladder wall or get good blood flow. Do you work out? I live in a small town, don't have therapy here. I'm very careful with my workouts. I'm not going to do anything which is going to stress and strain my pelvic floor in a bad way. I walk every day. I do weights, hand weights. I'm anxious to get back to the gym. Rowing is a great sport for an IC patient because rowing isn't going to stress the bladder or the pelvic floor really at all. But Laura, it really begins kind of with your age and the quality and health of your skin. If you're on birth control, if you're on Lupron, or you're just getting older, your skin's going to get drier. And that's where we start using topical estrogen. And at the same sense, we got to clean up our diet. There are people out there who diagnosed with IC, very, very severe symptoms, and yet they're still drinking their diet sodas every day, not understanding that the diet soda and the coffee is causing their nighttime frequency. So you got to clean up your diet and give your bladder a good opportunity to heal. And that means you got to be on the IC diet for several months. Just calm things down there. Your job is to create an environment that will support bladder healing. Jolene says, thank you for your time. I really appreciate and enjoy you. I hope you have a nice evening. You too, Jolene. You too. Thank you. Thank you so much. Diane says, I have pain when my bladder is filling or full, which doesn't hold much, and the pain goes away or decreases a lot after I urinate. So, Diane, that's pointing to your bladder wall as the source of your pain. So now we have to figure out, there are a couple of things we have to figure out. Number one, do you have a chemical injury of your bladder? Like, so these are the people who develop bladder symptoms while they're going through chemotherapy because the chemicals of the chemo damage the bladder wall. So the bladder, like any other part of the body, can be hurt, and it's hurt through chemical exposure. So if you're drinking a lot of coffee or soda or energy drink, that would probably put you into the chemical injury group. And our treatment here is to get rid of the chemical injury and give the bladder time to heal. The second thing we're going to look for in this group is we're going to look for the health of your skin and estrogen level. Because again, if you're low in estrogen, that's going to directly affect your bladder, and it's going to make your bladder more vulnerable. And the third thing we want to look for is there a possible infection, a chronic infection, especially a chronic fungal infection. So those are the three things that we look for in patients who have very persistent bladder wall-driven symptoms. Diane says, how long does it take when using a pelvic wand to calm down tight muscles? Like 10 to 15 minutes or less? For me, it's very fast, 5 minutes. 5 minutes. If I just work with that muscle for 5 minutes, I can get things to calm down. Hello, my man, John. Nice to see you. Could you go through the steps of calming the nervous system? Actually, I just had them open. Where did I have them open? Hold on. I just literally, before I started this meeting, I had them open. Hold on a sec. I have too many files open on my workhorse computer. Here it is. I got it. I got it, my friend. I got it. Okay. So I could read this to you, but there's a lot of, let's see. How to reduce nervous system windup. This was Dr. Alexandra Millspa gave a fabulous approach. So the first thing that she suggested was something called reflexercise. Lori, thank you so much for the 200 stars. So reflexercise was developed by Scott Musgrave, can calm the vagal nerve response. It's simple to do and basically reminds your body through its position to leave the fight or flight response. So when standing, so stand up, here, we can all stand up. Curl your toes into the ground as if you are gripping the surface. You're not running away, you're anchored to the ground. So stand up, curl your toes into the ground. Then open your arms to the side with the palms facing forward. Your hands are not clenched, but relaxed and open. The front of your body is open and receptive, not hunched. Then turn your head from one side to the other, gently loosening your neck. Let's do that. Close your eyes. Then put your tongue between your teeth. Take 3 deep breaths, and at the end, think about something that you love. Okay, so let me repeat this. So this is the reflexercise approach to calming the central nervous system. So number 1, curl your toes, stand up, curl your toes into the ground as if you're gripping the surface. Then open your arms wide. Your hands are not clutched, but relax and open. The front of your body is open and receptive to the world. Turn your head from side to side. God, my neck is so freaking tight. It's ridiculous. Close your eyes. Put your tongue between your teeth. Take 3 deep breaths, and at the end, think about something that you love. So, think of something that you love. What do I love? I love cats. So I'll think of my cat, my soul sister, Sammy. She said, Dr. Millspot said, we are intentionally holding the body posture in the opposite way that would happen with fight or flight. We can shift and neutralize the anxiety and trauma response in the moment. Okay. Now, the second way to do it is with what they call the power pose. Remind your body what it feels like to be in control. Amy Cuddy gave a fabulous TED talk about how body posture influences your attitude, brain, and nervous system. So stand tall, legs spread, chin up, with your arms on your hips like Superman. This or the Wonder Woman pose. Make yourself big and hold it for 2 minutes. Okay. She also talks, John, about diaphragmatic breathing. They talk about inversion. They talk about tapping, using emotional tapping. Dr. Millspot swears by the use of emotional freedom tapping, a form of psychological acupressure that actually helps turn off the amygdala and the stress response. This uses fingertip tapping at meridian points to balance energy by sending signals to the parts of the brain that control stress. It can and should be used when you're feeling anxious, stressed, or would like to address a specific issue. It has been studied with veterans with PTSD, and within 1 month, these patients had significantly reduced stress. EFT should be used on one problem at a time. So, number one, identify the issue you want to work with. So, for me, that's taking my blood pressure. That's become a hot button for me. On a scale of 1 to 10, with 10 being the most difficult, I'm going to say it's like a 7 for me. Number 2, rate your initial fear on a scale of 1 to 10. Number 3, pick a phrase that explains what you're trying to address. Even though my blood pressure is controlled, I shouldn't have any fear taking my blood pressure. And then you tap each meridian point 7 times as you repeat your statement. So you start here at the karate chop on your hand 7 times while you repeat the phrase, I can take my blood pressure. Then you go to your eyebrows. Here, tap 7 times. I can do all things. Then you go to the side of your eyes here 7 times. And actually, in this article that I'm reading that we did in our magazine, we were doing it about bladder pain. So it's, even though I have bladder pain, I deeply and completely accept myself or whatever. Then you go under the eyes right here. Then you go under the nose. Then you go under the mouth. And then you go right below your collar button 7 times. And then you go under your armpit 7 times. And then you go to the top of your head. EFT, that's called E as in Eric, F as in Frank, T as in Tom. You can see a lot of videos on YouTube about that. Oh, and then the I Spy technique. John, if you want to, so let's do the I Spy technique real quick. So you have to remember that the language of fight or flight is sensory information. You can't stop fight or flight thinking about it. You have to prove to your brain, your sympathetic nervous system, that you're perfectly safe. And the way you do that is with good sensory information. And so with the I Spy technique, what we're going to do is we're going to use sensory information to turn off your amygdala and turn off fight or flight. It works every time. It's just one rule. Absolutely one rule. You cannot mention I see it all when you do this. So let's do the I Spy technique. You know what? Because I do it almost every day with patients. It's so good. It works so well. So for anybody out there with anxiety, or if you have anxious children, this is great to do with anxious children. So again, we're going to prove to your brain you're perfectly safe, and we're going to get it out of fight or flight. It works every single time. Okay. So let's go ahead and take 2 breaths. Let's just go in for 3 and out for 3. And we're going to go in for 3 and out for 3. Okay. I want you to pick something in your environment right now, something that you really like. So I'm looking out a window right now and I can see a bird nest in a tree, in a big tree. But it can be a painting on a wall, it can be a dog or cat sleeping, it could be just whatever. Pick something in your room or out the window that you like, and I just want you to focus on it for a couple of seconds. That's all, just a couple of seconds. It's a bird nest. It's a crow bird nest. There's probably babies up there right now. Okay? Deep breath in and a deep breath out. Okay, now I want you to take a breath. Well, we did just take a breath. We're going to use the sense of smell. What can you smell right now? Are there any odors in your room? They can be good or bad odors. It doesn't matter. All we're doing is we're turning on smell receptors in the brain. So just sniff. Can you smell anything? And I can smell a smoothie. So focus on that smell, couple of seconds. And it's okay if you don't smell anything, that's fine. Deep breath in and a deep breath out. Now we're going to go to the sense of hearing. Besides my voice, are there any sounds that can you hear? Do you hear TV on, music on? Do you hear the wind, a furnace? Stop for a moment and listen. Can you hear anything? If not, that's okay. But just listen for a moment. Okay? Deep breath in, deep breath out. Now we're going to go to the sense of taste. Are there any flavors in your mouth right now? Have you eaten or drunk anything recently? So for me, I've got fruit smoothie. Focus on any flavors in your mouth. Is it a good flavor? Is it a bad flavor? What is it? Okay. Deep breath in, deep breath out. Now I want you to take your hand and I want you to rub it up and down your leg. Just rub it up and down your thigh 10 times. All we're doing is we're lighting up touch receptors in the brain. There's no threat here, but we're making the brain work. The brain is paying attention. There's something happening. It's not bad, but there's something happening and it's monitoring it. Okay. Deep breath in, deep breath out. Okay, now comes the fun part. Again, no IC. You may not mention IC at all. What would you just love to look at that would put an immediate smile on your face? Would it be the ocean? Being at the beach? Would it be a waterfall? Would it be puppies, kittens, flowers, a grandchild, a child? What would you just love to look at that you know would make you very, very happy? Think about that for a moment. For me, it- it's almost always a warm, sunny day at the beach. If you know when you're at the beach that you're away from the stress of your daily life and your senses are alive with what's happening at the beach. So think about what's your favorite thing that you would just love to look at. And let's take a deep breath in and a deep breath out. Okay. What would you love to smell that would put an immediate smile on your face? What's your favorite smell? Is it coconut? Is it baking cookies? Baking apple pie? Is it fresh cotton sheets? Is it a rose? What would you just love to smell that would make you very, very happy? For me, every single time it's either a baking cinnamon roll or sea and ski suntan lotion. Because all my happy summer memories are all this it's the smell of sea and ski. And I have some, and I love the smell of it. So think about your favorite smell, and let's take a deep breath in and a deep breath out. Okay. What could you listen to that would put an immediate smile on your face? David, hold that thought. What's your favorite thing in the world to listen to? Would it be ocean waves? Would it be a waterfall? Would it be laughter? What would that be? Close your eyes and imagine it. For me, Winnie the Pooh doesn't know what to do. Got a honey jar stuck on his nose. Kenny Loggins. That's my favorite. That's my favorite songs right now. So close your eyes and imagine your favorite sound, the laughter of your grandkids. Deep breath in, deep breath out. All right. What's your favorite thing to eat or drink? And again, no mentioning IC. What would you just love to eat or drink right now? And you know, when you put that first bite in your mouth, ah, heaven, my friends, heaven. A cinnamon roll has never tasted as good as during a pandemic, which is why I ate a lot of cinnamon rolls. But there's nothing, so imagine you're sitting at your table and you're either taking a drink of your favorite drink or you're taking a bite of that chocolate cake, that apple pie, that cinnamon roll, that steak. A lot of people talk about steak, barbecued steak. Imagine taking that bite and you just, oh, it's so good. Heaven. Deep breath in, deep breath out. And last but not least, what could you touch that would put an immediate smile on your face? Would it be fresh cotton sheets? Would it be the warm sand at a warm beach? Would it be a kitten or a puppy? Would it be your lover? Would it be a grandchild? What would you just love to touch that you know would put an immediate smile on your face? Can't go wrong with a cat. Cat in my lap, huge. Or dog. So close your eyes and imagine that you're touching. You can breathe with a cat in your lap. Deep breath in. Deep breath out. Right. How do you feel? How do you feel? Most of you should have a smile on your face right now because we just proved to your brain you're completely and totally safe right now. Fight or flight's gone. It'll stay out for hours. It will stay out for hours. But what turns it back on are negative thoughts. And that's the second half of this exercise. The legacy of widespread pain and having that childhood trauma is that your brain develops habits that become pervasive. When you're in fight or flight all the time, your brain starts to catastrophize. Hey, Jill, you want to go to a movie? No, I'll have a terrible flare. You want to go out to eat? No, I won't be able to eat anything at all. It'll be terrible. You want to go take a drive? No, it'll hurt really, really bad. That's a sign of catastrophic thinking. And whenever you have that catastrophic thought, you immediately go right back into fight or flight. So the second half of learning how to calm your central nervous system is to calm those catastrophic thoughts. And it's actually really quite easy. So I learned this in an anxiety management class that I took when I was 35, 28 years ago. Completely changed my life. I have not had a panic attack since I've taken that class, and I've only come close once. So what was cool about that class is it was developed by a physician who had anxiety disorder. And they said, listen, we're not here to psychoanalyze you at all. We're not going to talk about your childhood. Something happened in your childhood you want to talk about, we'll make that happen for you, but not here. Because the purpose of this class is to get you out of fight or flight. So how are we going to do that? We're going to do that with adrenaline. We're going to get rid of all the adrenaline circulating through your bloodstream. Because every time you have a negative thought, you give yourself a jolt of adrenaline. And you don't just have one negative thought, you have like 100 shots of adrenaline floating through your brain at any given time when you've got anxiety disorder. And he says, you know how you're sensitive to chemicals on the outside, because all those nerves are super sensitive now? You're also sensitive to the chemicals on the inside. And right now, you're basically overdosing on adrenaline. There's so much adrenaline circulating through your bloodstream. That's what's driving everything. That's the engine. That's what's driving the panic. That's what's driving the high heart rate. That's what's driving all of this. It's just this massive continual production of adrenaline. And he said, the secret to getting you out of fight or flight is to lose the adrenaline. And losing the adrenaline is really easy because oxygen turns the adrenaline off. Oxygen turns adrenaline off. So he taught us a 3-step technique that whenever you have a negative thought, the very first thing you want to do is visualize a stop sign. Just stop. And the thing is, you get so sick of the negative thoughts, you're doing it anyway, but just for God's sake, stop it. I don't want to hear it. Stop. And then you take a single deep breath. You go in and out. And that oxygen from that negative thought has now completely taken away the adrenaline. It has rendered the adrenaline chemically neutral. So number 1, stop sign. Number 2, a deep breath. And number 3, you have to remind yourself it's a thought. It has absolutely no power. It's like, oh my God, Jill, you're not God. You can't predict the future. For all you know, tomorrow's going to be a great day of your life, one of the best days of your life. It's just your brain guarding you. It has no power. Let it go. Stop sign, deep breath, minimize the thought. And the instructor said, listen, that's our goal for this first week is we just need to get rid of all the adrenaline floating through your body. So I want you to do it. I want you to go home. Every time you have a negative thought, do it. Stop sign, deep breath, minimize the thought. The science makes total sense. We're trying to get rid of the accumulation of adrenaline that makes the anxiety go on and on and on. And of course, I had my first negative thought walking out of class. Oh my God, Jill, this is stupid. It'll never work. But I did it. Stop sign, deep breath, minimize the thought. And I easily did it 100 times that first day. The next day, I did it about 50 times. The third day, I did it about 20 times as my adrenaline was slowly going down because I wasn't letting it build up. 5 days later, once. I only had to do it once. And for the first time since 4th grade, when I was attacked by a rapist murderer, I was finally out of fight or flight. 4th grade to the age of 35, I was in fight or flight. That simple technique for a week got me out of fight or flight. Got rid of all the adrenaline. It was me learning how to stop those negative thoughts. I know I love Norman Vincent Peale, The Power of Positive Thinking. I'm very deliberate in how I live my life. You can see my office is a very happy office. The rooms are yellow. I like it. It makes me happy. I've got encouraging things everywhere. I've got signs that say love and peace and hope and comfort. I do my affirmations whenever I'm feeling down. I can do all things through my faith that strengthens me. And I will tell you, I went from having hundreds of negative thoughts a day to having maybe one a month. And I was that way took the class when I was 35 until the fire started and the pandemic started. And then the negative thoughts started coming back because I was trying to keep my parents alive. But I never let them get out of control. I went through a uterine cancer scare and emergency surgery. I had emergency surgery a month ago. I was doing it in the freaking car on the way to, no, except I was actually already in the emergency room. I was doing it in the car on my way to have my hysterectomy. And then a month ago, I was already in the ER and I was just doing it in the ER for hours until they could get me into the operating room. The goal here is to not let yourself have negative thought, adrenaline, negative thought, adrenaline, negative thought, adrenaline. If I have one negative thought, I'll let it go. And usually I will at least once a day ask if a natural disaster will happen. Is this the day the big earthquake or the fire is going to happen? But I usually do that once. And that's just PTSD. If I have 2 negative thoughts in a row, let me tell you, I do it. Stop sign, deep breath, minimize the thought. And I rarely ever get to 3. So that's the other piece of this puzzle here is if you've been in a fight or flight for a long time, you are living in the negative. And that's what an injured brain and an injured central nervous system does. You're just living with massive amounts of adrenaline floating through your body. So what we've got to do is get rid of that adrenaline. And the way we're going to do that is with oxygen. So stop sign, deep breath, minimize the thought. I double dog dare you to try this. I double dog dare you. Now, David, my dear friend, David, he says you're in the hospital. He says, Jill, I'm at the hospital. Pray for me. David, what's going on, honey? What's going on? Why are you at the hospital? If you're still here, pop me an email, icnetwork@mac.com. You're welcome to call me too. I'd love to hear from you and I'd love to know what's going on, my friend. Big, big, big hug. Everybody just take a moment. Take a moment right now. And I want you to send light and love to IC patient David. He's a good man. And he's having a bad moment right now at the hospital. So let's send him some love. Anybody who's having a flare, we're sending you love too. Paula says, I don't feel like I have anxiety, but I have IBS now after diverticulitis a year ago. I also have an enhanced smell, but again, I don't feel fight or flight. Do I have a sensitive nervous system, but don't know it? Urologist says my pelvic pain is from my pudendal neuralgia. Yeah. I mean, so you're in a good case, Paula. I mean, the good news is you're not living in anxiety. That's great. So you're more the injury trauma patient as compared to the abuse, or you're more the physical injury patient as compared to the trauma or abuse patient. So you had diverticulitis, and whatever happened with the diverticulitis, it might have messed up the biome in your bowel, or it might have messed up some nerves in your bowel, and that's why you might be having kind of general sensitivity in your bowel and then throughout the body. So And since your doctor says you've got some pudendal neuralgia, then we know we've got some nerve involvement going on. So what would be fascinating for you, Paula, would be maybe to try some Peora, some PEA 500, also known as palmitoyl ethanolamide. In the IC study done in 2019, 87% of patients, 87% of patients reported a significant reduction in their pain and discomfort by month 3. And so I took that European study to Natural Approach Nutrition and said, can you make it something like that for America? And they did. It's PEA 500. And that's what I use. The general consensus among the researchers out there is that it's just very, very good at calming the nervous system down. There were no side effects reported in the IC study in the great majority of studies, and there are no known drug interactions. Pretty much when you read those studies, and you can find studies for shingles and burning mouth syndrome and fibro, pelvic pain, male pelvic pain, IC, surgical pain, chronic pain, acute pain. And really the authors are quite astonished at how well it's tolerated. And so that's what I take to keep my nerves as calm as I can. Paula said PEA works for about 2 months and you go off of it and on it again. That's exactly what I do. Lori is asking for a link. Sure, I can give you a link for it. David, are you still here, honey? Are you still here? Let me give you a link. And also just FYI, we're getting our, we're out of stock right now, but we're getting our shipment this week. So if you can just hold tight. I talked to them Friday and they said they were going to ship it out this week. So we will have it soon. Have it soon. Diane says, I've been doing Pilates since starting back with pelvic floor therapy. It doesn't seem to bother my pelvic floor. There are some Pilates exercises that relax my pelvic floor. Yeah, Pilates is definitely preferred over yoga. But in both, there can be some positions that can be a little bit more irritating to the pelvic floor. So you just have to pay attention to that. And Gina says, great advice. Thank you, Gina. We try. All right, David, are you there? He might be talking to the doctors at the hospital. Shoot. Let me see if I have his email address. I want to reach out to him. As a support group leader, especially if you were in my area, the promise I make to everybody in my support groups who are local is if they're ever at the hospital and they need a buddy, that I would come down there, and I've done that many times. So if you're in Northern California and you're fairly close to where I am, and I'm if I can get there, I'll try to do it, because I know sometimes you just need somebody to sit with you. That was something I learned from my mom. My mom was just absolutely the best at being just sitting with anybody in the hospital. I swear I could feel her when I was in the hospital a month ago. Hold on, I'm just looking for David's email address. Darn it. I don't have it. Oh, wait, hold on. Shoot. David, if you're listening, honey, I don't have your email address. Love to talk to you. And if you want to talk, you can give me a phone call. shoot, 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 shoot. All right. Any more questions? Rhonda, I have a really interesting story. One of my members, Linda, she was in a coma. Linda, she was in my local group, and she ended up in a coma, and she was in a coma in the ICU for about a week. And every day I went and sat with her, and for about a half an hour, and I did a guided visualization with her. I did the pink balloon. It's either a pink or a red balloon, where basically you just imagine that you're holding a balloon, like a helium balloon, and all of your pain from wherever it is in your body travels up your body to your shoulder, down your arm, to your fingers, up the string into the balloon. And so, it's just wherever your pain is, just move it slowly. Let's get it up the balloon and watch the balloon get bigger and bigger and bigger. And after about 5 or 10 minutes, it's like, okay, now open your fingers and let it go. Just let it go. Right? I learned that when I was in graduate school. Anyway, she came out of her coma, and I went down and saw her, and she's like, "Jill, what's up with the balloon?" I'm like, what? She goes, "You kept talking about a balloon." But she was in a coma, guys. She was in a coma. She was unresponsive and on a ventilator. And yet she heard me talking about the balloon, and she said it helped. She said it helped. And so that's my personal testimony, that whenever you have somebody who's unconscious, you always talk to them. Always. Because while they might not have the ability to open their eyes, that doesn't mean that they're not listening. And by golly, she remembered the balloon, and it was fantastic. I just gave her a big hug, and she's like, "Thank you for being here. It was so great." I'm like, "Of course I would be here. I love you." You know. So, we did lose her, actually. She's no longer with us. She died not from that. Years and years and years later, she finally passed away of natural causes. So, I love thinking about my guardian angels. I think she's a guardian angel. And you all have guardian angels too. All right, guys. Well, it looks like we're kind of done with the questions, right? Any other questions out there? We've been going for about 3 hours now. Rhonda says, "Wow, yeah, I believe they can hear too." Yeah, I have no doubt. And I'm sure that my dad and my mom, next month is the 1 year anniversary of losing them. So we'll see how I am. The 12th and the 17th. I have to see if any of those are Sundays. Mother's Day. Shoot. I don't know what shape I'll be in that day, guys. Send me strength. That's the day my dad died. Oh, can't believe it. Thank you, Paula. You're a sweetie. All right, guys. Well, I think we're going to call it here. David, if you happen to be listening, honey, we're sending you lots of love, and we're absolutely praying for you. And if you can, give me a phone call, okay? I have I'm not going anywhere today, so I will be here. So if I hear the phone, I will answer it if you want to talk. Okay, I will try to answer it. Be persistent, but just know we're sending you lots of love. All right, guys, we're gonna say goodbye to YouTube first. See you later, YouTube. Have a good one. See you next week, hopefully. Knock on wood. That's not a negative thought. I did not catastrophize.